Dr. Jeanne Jakob, thanks so much for joining me on the show today.
Thank you, Aaron. I'd been following your work on LinkedIn, and I just really appreciate everything that you do to get the word out about addiction and substance use. And so I was kind of really, it was cool to see that we both trained at the Ann Arbor VA, and somehow we didn't meet when we were there, but now we connected now, so that's just really cool. So thank you for having me on the show. I think what I'm going to talk about today, PTSD trauma, it's one of those topics, I think, similar to substance use that there can be a lot of misinformation about, a lot of shame. And I think that it's really important that we help the general public know about these things and know about that there's help out there and also to kind of demystify some of the aspects of these struggles and also what psychotherapy is. So thank you. Thank you so much.
Of course, I know I was thrilled when you reached out. I was like, oh man, another board certified Ann Arbor VA trained psychologist. I got to have her on here. And in part because I haven't done an episode on trauma. And that's actually a gap, I think, in terms of the podcast, because it's a problem that is unfortunately so common and so prevalent and in many cases so misunderstood, I think, both by the general public as well as even sometimes folks who are going through it. I think that there's a lot of preconceived notions. So that's actually where I'd like us to start, which is what is trauma? We use that word a lot, sometimes inaccurately. So from a clinical perspective, from someone who does this work very often, how do we define trauma and why does the definition of trauma matter?
Yeah, that's a great question. And I'll just kind of start with saying I've put in a lot of time and effort into building a platform, my website, insideout.com, psychinsideout.com. And there's a whole section in the resources on PTSD trauma, very comprehensive. So if anyone is looking for more reading or vetted resources, please go to psychinsideout.com and you will get a lot more information there. But to kind of circle back to your question about trauma, you're right. Trauma is one of those topics that, psychology topics that you hear about in kind of the general, culture. And I think we as clinicians and as psychologists, especially those that specialize in trauma and PTSD, we've kind of learned about trauma in a much more academic way. And so just to kind of give your listeners some sense of what is trauma, in terms of the clinical kind of academic definition of trauma, trauma is technically defined as an experience that is outside the range of kind of normal everyday human stress, which we all experience. Trauma is something that kind of shakes the body's sense of safety and trust. And so there's a lot of ways that when people experience traumatic events, the kind of natural part of their system, their fight, flight, freeze system, kind of gets a little messed up in that. And so trauma itself is typically something that is an experience that is not a typical stressor. So we're talking about things like physical assault, sexual assault, combat, really kind of a lot of injuries, motor vehicle accidents. So I'm giving you kind of a sampling. And those in the kind of DSM, which is the Diagnostic Statistical Manual that we as psychologists always kind of consult with, those kind of constitute traumatic events. And those kinds of traumas need to kind of be present to technically qualify for a PTSD diagnosis. So I'll kind of stop there. I want to kind of get into a little bit of what big T and little T trauma is, because that's something that a lot of people talk about But I'm really, those ones that I talked about right now are kind of the big T trauma ones, the ones that are, and I'll say more too at some point, but
Yeah, well, we
unfortunately,
can
we'll keep going.
well, we can dive into that too, and I,
Yeah.
I am curious about that because we hear that, right? Big T trauma and little T trauma, or some people, and not to say that this is a characterization that's not okay to use, but people will say like I went through a really traumatic breakup, or they'll
Mhm.
think about something that was really embarrassing that happened, and
Yeah.
they'll use the word trauma, which isn't to diminish their experience of those situations or the impact. I'm wondering though, like clinically, and maybe this is your big T little T differentiation. Do we look at those types of jarring experiences differently? Where one is there's a threat to your physical well being or your life, versus another one is more of just I shouldn't say the word just, but it has more to do with
Yeah.
an emotional jarring rather than something that's physical as well,
Yeah.
safety related.
Well, I think that one of the other things about kind of the diagnosis of PTSD and then also the use of this word trauma is a lot of times people kind of conflate the two. Kind of people kind of, say, oh, I had trauma, I had PTSD. And it's very different, actually. Experiencing a traumatic event does not mean you have PTSD. So you don't treat trauma, you treat PTSD. And so just by virtue of having hard, and what that trauma is, we could say could be, people can think of it as I was traumatized because I had a really hard breakup, or I was traumatized because I was in a really, challenging relationship. And I think we kind of sometimes people mix up the two. And part of what to kind of move into the PTSD realm of a diagnosis is not only do you have to have the trauma, but you also have kind of a constellation of symptoms that are pretty persistent and pervasive and impairing. And so when we talk about more little T traumas, I don't think of it. I guess I'm really a clinician at heart, and if someone's little T trauma doesn't technically meet criteria for PTSD, maybe it does, because I think that some little T, like there's a little, subjective piece of this. But even if it doesn't meet the criteria for PTSD, I'm still thinking about it through a lens of this was an impactful, painful experience that probably
Yeah.
shifted someone's worldview, their behaviors, and so forth. So, yeah.
hmm Yeah, and I think we'll probably get into the symptoms in just a minute of things to watch for. But I know, so I'm very strongly oriented with the cognitive and cognitive behavioral treatment modalities of PTSD, which I know we'll get into in a bit. But there's also, I think, baked into that an idea of, so how does it explain the formation of trauma? And I like to think about it personally. I'd love to get your take on this. That it's a combination of an adrenaline response to a memory, as well as learning things about
Mhm.
yourself or other people that may not be entirely accurate. And certainly there's, the adrenaline response, when I think about like PTSD versus just being really shook up by something or being traumatized, little t, that's, I think, one of those main differentiators. Do you have a fight or flight response? The
Correct.
learning can happen in all sorts of different situations of different intensities, and that could still make a huge impact on somebody's life.
Sure. Yeah. Yeah, there's so much in here. And we could probably talk not just big T, little T trauma, but also something more of like acute incident trauma versus something more chronic, especially in when we're thinking about developmental trauma, where there might be some kind of chronic relational trauma that happens over the course of one's development. And so there's a lot of different parts of this we could talk about. But in terms of this kind of what you were talking about, the adrenaline response, so when someone experiences a traumatic event, oftentimes the fight, flight, freeze system does get activated because that's what it's supposed to do. It's trying to protect the system, against harm. And so it's actually, we're often working really well in the moments of, being on the receiving end of a traumatic event. Where that goes awry is often in the kind of post-traumatic recovery period. And for a lot of people experiencing traumatic events, there's actually a lot of natural recovery that can just happen with time and exposure to like being in the world. And so, it's actually not as, it's like 70% of people, or maybe 60 to 70, experience a trauma in the course of their lives. So the prevalence of PTSD is really more like 7%. So clearly there's a lot of people that kind of experience things, but they recover. I think where the people that kind of struggle after experience is that they get into patterns of avoidance. They get into patterns of avoiding of the memories, avoiding of thinking about it. So avoiding being around situations that remind them of the trauma. And so when that starts to become a recurring pattern after a traumatic experience, the body and system don't get to relearn or learn how to be more comfortable in the world, is the way to put it. So, so the adrenaline response is important, but I also think it's not the only thing, because I think that happens across any, I would have that response if I got in a car accident, today. I'm not necessarily going to develop PTSD.
Right, right. I think for me, it's like the adrenaline response being at a time then. I like to think of it, and again, I'd love to get your take if this is how you think of it too, like a crossed wire between the past and the present. So like if you're noticing that, like say you were driving and you're just driving along minding your own business and like a deer pops out and you end up hitting it and you go to the hospital, really awful experience. You get in the car again and you feel that sense of tension because there's that association, right? Like here's a car, maybe even the same one. I'm in the driver's seat. You're thinking this might mean a deer's going to jump out, even though that's a very low likelihood event. And so your body gets you ready as if you're
Yep.
going to get hurt again, even though in that moment you're not in danger in the same
Yes.
way. And that's how I like to think about it. It's like
Yeah,
you're taking
I
the
think
past and
about
you're
it
bringing it in.
totally. And it's like the body kind of gets conditioned to that stimuli. And then so even though you're getting in the car again and there's no deer, it's made this direct connection with the car and that experience. And if you start to avoid going in the car, if you start to avoid driving, your system's never going to learn that it's actually okay to drive. So there's a
Right, right.
big avoidance feedback loop that I think puts people at a lot of risk for developing more problematic symptoms after trauma. Um,
Hmm.
and yeah, and I think there's also, there's a lot of the people who are really in this, the academics of the world who study what are the factors that create, going from a traumatic event to PTSD. They look at all these factors. What are risk factors? What are protective factors? So I don't think it's one single thing. I think there's a lot of things, and the aspiring psychologists of the world go and do that research because we want to understand what puts people at risk. Because unfortunately, we experience a lot of trauma in our world. It's unfortunate, but it's true.
Yeah, we do. Although I don't know if this has been your experience, but I found that treating PTSD, at least from an evidence-based perspective, is actually effective the vast majority of the time in terms of reducing those symptoms. I think if there's
Totally.
any, yeah, if there's any silver lining to it, it's that I think people, they oftentimes, because avoidance is part of the pathology, they sit with it for years and they think that this is just the way they are, the way life is. But once they come to treatment, things can get so much better.
Totally. When I was working, I worked as a study therapist on a number of prolonged exposure therapy clinical trials. And so I had to learn this treatment in, 10-session treatment to treat people who had PTSD. And, you think, what, 10 sessions? Is this going to really work? And, if it's the right fit of a client and also what their presentation is, um, it's amazing to see kind of what can happen in a short amount of time when you really do some focused memory work paired with
Hmm.
focused exposure in the world work. It's really quite profound. So now I'm a clinician in the kind of the real world. So it's different. Trauma treatment in this space looks different than in a research lab. But I'm always thinking about, I think the core of any effective trauma treatment has to involve some direct memory work of some sort and current present day exposure work out in the world, doing things, trying to kind of create that feedback corrective loop that's the
Yeah,
underpinning
yeah.
to a lot of avoidance.
Mm-hmm. Like you go through a traumatic event and it can teach your body and your mind things some very quickly, but the process of
Yeah.
teaching yourself something different on purpose later, you can't like brand it into you in the way that the trauma did. You have to do it consistently and repetitively over time.
I think of that as like exposure. I wish there was another name for exposure therapy because I think people "Ooh, exposure, but it's really just it could be a deterrent. I think to getting effective treatment. It's really about
Yeah.
yeah, getting back into life and doing things so that your life can be fuller and richer and oftentimes PTSD can kind of really make one's world start to get really small.
Hmm.
So it's really powerful treatment. I really hope people are understand that there's really good help out there. There's, and that with a good therapist, there's so much in terms of recovery that can be available to people.
It can get better. Yeah, it's a really good point about the word exposure. It does sound either like embarrassing or
It's true. It's
uncomfortable in
like,
some way. We
yeah,
should talk to like NFO and be like, all right, let's call
let's
this
rebrand
like
this word
target.
exposure therapy. Let's
Yeah,
rebrand.
well, let's call it experiential learning therapy. How about that?
That's too
Just
academic. I think we need
no, it's
something
true.
like just do it. I don't know, like
Just do it
or you
therapy.
can, yes you can. Like a lot of I have two little school age kids and it's so cool to see how the culture is changing in terms of, how we frame things. Our language is really powerful and so I think we can do a better job as a profession, maybe rebranding some of our labels so that they're a little bit more soft and welcoming.
Yeah. Well, speaking of labels and definitions, so I know
Yeah.
that the how we categorize and think about trauma has changed over the years. Can
Yeah.
you walk us through so what our understanding is now compared to what it was before?
Yeah. Well, the DSM is our Bible, and as a psychologist, right? It was the first DSM was 1950 something too, 54. We're a pretty young field, actually. If we want to think about it from the DSM piece, PTSD actually didn't enter into the DSM until 1980. So it's a third edition. And prior to that, there was discussion of things like shell shock and combat fatigue, but there wasn't really like a diagnosis. Um, ha- that diagnosis has also changed. We're in now DSM 5, TR. It's changed. And the most recent version actually kind of what we were talking about before, it's taken out one of the criteria that I was trained in. So when I trained in the mid 2000s, you had to have not only just a traumatic experience, but you also had to experience fear, helplessness, and horror at the time of the trauma. That
Hmm.
criterion has gone away. So there's actually, and we could, it's deeper than, but the idea is that what I'm trying to kind of say is that these disorders or these conditions, they've changed, they kind of change, and it's based on research. It's based on us learning more information. But it's a little bit, we're still in this young kind of, it's a moving target a bit. So um, how it's changed over the years, I think right now, when we think about what PTSD is, having to have the trauma, you can have all the symptoms of PTSD, but if there's no trauma, then you don't have PTSD. You have other things, but you don't have PTSD. So the other symptoms and signal and kind of the syndrome of PTSD involves um, not just the trauma, but then also a pattern kind of post a month out from the trauma. So if you have a little symptoms kind of right in the first month after experience, that's actually kind of normal. They call that
Hmm.
acute stress disorder. But when those symptoms start to perpetuate, and the symptoms are things like re-experiencing symptoms like having flashbacks, nightmares, intrusive memories about what happened, um, paired with a lot of avoidance around any kind of associated experiences or memories or experiences, paired with heightened agitation, kind of that fight flight system. So maybe more irritability, more touchiness, more recklessness. And then also the fourth kind of domain is changes in kind of your mood and sense of self. So negative perceptions about yourself, the world, oftentimes depression, insomnia. So those are kind of the constellation of symptoms. And those things have to be pretty impairing, like, not just every once in a while, they have to be kind of at a level of more days than not, some of these symptoms are happening for you. So, so that's where we're at right now in terms of a PTSD diagnosis. There's a lot of other diagnoses that I think people can have post-traumatic experiences. But
Sure.
that's what the technical PTSD diagnosis is about.
Yeah, well, and I appreciate the breakdown as well as putting the clusters out there in terms of helping people understand, because I think that the I know there's some people who are all for diagnoses, and there are some who are really opposed to like the DSM is on principle and the idea like we need to have more of a continuum versus categorization. I think though what's useful about diagnoses is that they can guide treatment, and I think when done properly, you don't want someone identifying with a label, being like, I am this way because I
Yeah,
have PTSD or my trauma defines me. But at the same time, I think when you can say, hey, this looks like the problem that you're having, and that means we have these treatments available that have been researched, that have been tested, that can actually give people a sense of hope as well.
totally. Yeah. I think the over-identification with certain labels and diagnoses, that can be a helpful piece of that for some folks. It's kind of an individual, is it helping or is it hurting kind of thing?
Mhm.
But I think that on the whole, I think any diagnosis, it's not the whole of a person,
Yeah.
but it is an important piece to really do a careful assessment. And I think that as psychologists, we get a lot of training in assessment so that we can kind
Hmm.
of conceptualize and come to that label, because that label does help to guide what we're going to do in terms of treatment. And so I think there's a real use and utility to have the DSM, and it's still an evolving thing, and it's our best thing we have right now to kind of share language and so forth. But I agree with you, like these diagnoses um, are just a part of what a person's struggling with, and they don't have to be the whole of who they are. In
Yeah.
fact, the whole goal is to get them to be who they are more once they treat the diagnosis.
Yeah. I will say though, it's amazing in a negative way, but it's just
Mm,
incredible how I almost view it like it's like an octopus or like a spider web in a way, where how much trauma and PTSD can touch somebody's life and change how
yeah,
they act on a day-to-day basis.
yeah,
I know some folks come and they think that they need treatment for depression, or they need treatment for generalized anxiety, or they can't focus, or and really what's going on is that there's this traumatic stress, and once you resolve that problem, they're sleeping better and they're concentrating better, and
yeah,
their self-esteem is so much better, and they're not anxious and edgy all the time, and there's and so I always, if someone's been through a traumatic event and they seem to have post-traumatic stress disorder, I always like to put out there, like, if you're up for it, let's treat the trauma first, like let's do a focused treatment on that and then see what's left over afterwards, because you might find that you're a lot better at that
yeah.
point.
I agree. It's like yeah, and I think that's, as clinicians, we're kind of skilled to kind of look at a little bit of the etiology or the cause of the symptoms, and if trauma is really, all roads lead back to traumatic experiences, then we really want to work with that.
Yeah, like let's get at the core.
Yeah.
Well, so speaking of the core, when we talk about trauma, I know a lot of times there are some folks who go through something that's more recent. Like, for example, I actually live about 15 minutes away from the July 4th shooting that happened a year or two ago in Highland
Oh,
Park.
yeah.
Yeah, and so there was a lot. I actually worked with someone who was at the event. There's a lot of things that can happen in someone's adult life even that
Sure.
leave that traumatic mark.
Sure.
However, a lot of times when folks come, it has more to do with their childhood and things that happened when they
Yeah.
were kids, potentially chronically over time in the
Yeah.
case of, say, abuse or neglect, or even just specific instances. Why does it seem like, or if you would agree with that statement, why does it seem like childhood events have this outsized impact
Oh,
on
yeah.
folks' functioning and in terms of causing PTSD?
Yeah. Well, as a mom myself, I'm just, and as someone who started out my career really focusing on child and adolescent development and working with kids, I've evolved to work more with adults now. But I don't think you can treat actually adults without having a perspective on child development and some understanding of that piece of the lifespan development phase of things. I think, what do we know about the brain? The brain is so malleable, is so plastic, is so receptive at younger ages. And it's, I like to think as I'm coming to my 45th year in life that my brain is still plastic, but it's not like how it was when I was a baby, right? You learn language without doing anything. So the
just
brain
wait, they're going to update the operating system on your phone and everything's going to just end for you.
Right. So I think it makes a lot of sense that when kiddos have experienced either an acute trauma or a chronic, developmental, like especially in attachment relationships, important figures in their lives who they're dependent on for survival. And yet at times those people are those individuals for different reasons. And I always kind of am thinking that there's a reason for everything. And even people who perpetrate, I want to they deserve some work too, some treatment too. And so I think that kids and teens, when you experience something, when your brain is so plastic and so receptive and spongy, it's going to have an impact on how you view the world, how you view yourself. It's kind of like that's where we learn about things, right? It's not until you kind of leave the home where you start to get exposed to other realities. So I think when it's experienced in these formative times of development, it leaves an impact in the brain. Now, is that hopeless? No, I think it's totally actually hopeful for adults. You don't have to, no matter how old you are, that there can still be recovery from childhood experiences. But yeah, I do think there's, in my clinical practice, I see that too. There is a bit of a different presentation for folks who've had some childhood developmental trauma. And I really appreciated the work of Marilene Cloytra on really kind of creating a protocol that's particular for survivors of childhood abuse. And she melds in some exposure stuff, but also just some kind of specific stuff around childhood abuse in particular. So,
yeah. Well, I think that was a beautiful answer. For me, just adding a little bit onto that, and I'd love to get your thoughts too. I think that, if I was going to sum it up, when we're young, not only are it's like the worst possible combination because we are learning how, like, what the world is like and whether or not, like, can we trust people? Am I safe? What can I depend on? At the time when our brain is the least able to make sense of what we're going through. And so we tend to just make connections sometimes, and people, like, if say a young child only gets attention when they get good grades, say, for example, they might learn, like, my worth comes from being perfect, or my worth comes from not making mistakes. Or maybe if I was a better kid, I would get attention anyway. There must be something wrong with me. People get what they deserve. There's all these conclusions that we sometimes even unconsciously come to because we're just trying to figure out why, like, this is happening to you and your needs aren't being met. And you don't say anything about it. You just kind of, like, come up with the schema, this heuristic, and then find
the heuristic,
confirmatory information.
Yep. Totally. Yeah. And I've really kind of grown to be an acceptance and commitment therapy clinician. And in that framework, this is like all the programming. It's like we're brains are kind of like a computer. We're getting programmed at an early age. And if, it's kind of shaping our perspective. And so I think if our experience has been one of trauma or chronic trauma, that's going to shape our belief systems. It's going to shape our behaviors. It's going to shape our kind of biology. And so I always think about it in terms of that, like, it's gene environment stuff, right? You can't, it's a combo of those things, because there are people who experience horrific childhoods and they seem to recover naturally without a lot of help, and so I think, but I think, I think I'll just say this. I think anyone can benefit from going to therapy in general. So we could talk about that, just psychotherapy in general, because that's kind of part of my mission, is to help people feel open and, like, to kind of demystify what psychotherapy is and also help people become more
Mhm.
educated consumers so that they can find the right therapy and therapist for them. Because I think
Yeah.
it's all about that fit.
Well, we will definitely come back to that because I will say for someone who even who's in the industry and who's in the treatment world, it is so hard to figure out who to go with and connect someone if they have to use insurance or who looks like they've been trained properly,
Yeah.
those sorts of things. Before we get to that side though, one more question on the trauma specific
Sure.
treatment side. So there are some evidence-based treatments for trauma. Some
Yep.
that are viewed as quote unquote gold standard, have a lot of research. Some that are take a different approach, more of a somatic body-related approach,
Yeah.
but still have evidence behind them. Could you just give us a quick run
Yep.
through of
Sure.
if someone wants to treat trauma, what they should be looking for in terms of evidence-based approaches?
Yeah. So, two resources for people just in general is the National Center for PTSD. That website, you could say, is like a one-stop shop for anything related to PTSD and trauma. So that's for clinicians, that's for consumers, that's the general public. So National Center for PTSD, that's the VA. I mean, that's the gold standard in terms of finding really good information about trauma treatment. And also, I'm building my website, so psychinsideout.com. Go there for some stuff that I've vetted. So I'm going to, we both trained in the VA. So we know in the VA, right, working with veterans, we trained a little around the same eras, prolonged exposure therapy, cognitive processing therapy. Those are really the two that have received the most, let's call it, research evidence and clinical trial work to show that they can be incredibly effective at treating PTSD. There are other treatments, though, and you'll see this, that these treatments actually are not very common in the private practice world. Or I could say there's competing treatments that are out there that I think consumers wonder about and get curious about. One is EMDR. Oh gosh, I don't know. Do you know what I should know this. EMDR. We'll just say EMDR.
It's
I didn't
eye movement desensitization reprocessing,
Yeah,
I
thank
believe.
you. Yeah. Too many acronyms, too many letters. I mean, we have that we're all guilty of that in our field. Um, EMDR, when I was trained, it wasn't seen as having the most evidence as like PE and CPT. I think it's shifted because I think there is more research. So that's also kind of been exalted as one of the kind of evidence-based treatments for PTSD. I also have seen offshoots that are kind of bringing components of these treatments into different, formats. So written exposure therapy. There's actually a great book that's like clinicians can do with clients, and it's I don't have it. It's on my bookshelf. It's 4 sessions, I think, 4 to 5 sessions, and doing exposure through writing. So written exposure therapy. And then the other one that I kind of talked about before is Marilyn Kloitra's STARE model, because I think her STARE model also brings in some elements of DBT, dialectical behavior therapy, that can be helpful as an add-on for people who may have had chronic childhood abuse experiences. So those are the ones that I would kind of put out there. There are other ones that maybe have less research clinical trial data. Does that mean that they're not effective? I usually say, we don't know. So part of it is some of this, it hasn't been tested in the way that PE and CPT have been tested. And clients, consumers also, they may have their preferences around how they get trauma treatment. And so I'm more of the, if something's working for an individual, if their life is getting better, I'm all for that. So, yeah. Would you piggyback on any other treatments? I mean, I could speak about different ones, but those are the 4 that I would kind of highlight. Any other trauma treatments that you've heard in the general,
those are the ones that I know of being the most common. I know for me, I use CPT most of the time. That's the one where I got cognitive processing. That's the one where I got the most training, and it's just worked very well for me over the years.
Yeah.
What I would say most of all, though, if there's anyone listening who's wondering about like how do I find a therapist for this, or for a loved one or someone I care about, it would be just making sure that they can articulate the methods that they're using, and that it's probably one of those four, or if it's not, that they're clear about how it's a different method or it's a new method. Because one of my, and this might just be my own prejudices from being trained in the VA, where they care very much about, getting people better in an time effective manner. But is that there's a lot of folks I've worked with who have gone to therapy for PTSD, where it seems like the therapist was just kind of talking with them about it. And maybe it's something that and this is going to sound a little pejorative maybe, but I'm just going to put it out there. I call it hug therapy, because it feels good in the moment. It's like you're talking with someone. It's like you're getting this psychological hug. You like the session. Maybe the therapist likes the session in a way, right? Everyone's enjoying themselves. But then you leave and the symptoms don't improve.
Yeah.
And that's the only sort of thing that I would definitely watch out for, is just to make sure that you're working with someone who can really say, this is the method that I'm using. The symptoms should go down. Here's how I know that that's the case. It's not something that should be, in my opinion, wishy-washy, because PTSD and trauma can be so disruptive to life, and because there are ways to actually make it better.
Yeah. I love that we could have another episode on hug therapy, and I have a little different take on it. Because I still go back to kind of that stuff as like the therapeutic relationship is one of the most, important ingredients to effective psychotherapy. And I think both of those things can be present. I think the hug can be present with the effective intervention. And in fact, those two things married, I think probably make the most impact.
Yeah.
That's why I kind of don't think, I hope that apps that want to be therapists will, replace our, us, because I think there's a human element to this relationship that can be healing, but it can't be the only component of it. And so people have to feel safe. They have to feel like the therapist knows what they're doing. They have to feel like something's changing in their outside world, and that they don't get kind of just attached to the once a week. That feels good.
Yeah.
And I go back to where my life doesn't feel good, but that feels good, right? That we don't want to prime just that kind of model of psychotherapy. We want to extend it into their worlds. I like to think of it as like, I want people to move into their world, make their lives different. I don't want them to stay with me forever. Although some people, I think long-term therapy can be really beneficial and grow their lives as well. So I'm not anti long-term therapy. But I think you really want to be with a good therapist who has the eye on making this person's life bigger and connected in their day-to-day life, not just the therapy office.
Totally. And yes, I completely agree with your sentiment about how therapy should actually feel welcoming and warm and safe. It just shouldn't, like you're saying, stop there. It really should extend beyond and improve somebody's life. And that's a great segue to talk more about the work that you're doing on helping people find therapists who do that for them, where they feel that connection, they've got a great rapport, but then they're also making progress, because there are a lot of folks. I mean, I'm sure I'm part of someone's terrible therapy history for some people as well, where they're like, oh man, that therapist I saw, but this, that, and the other thing. But what I will say is that there are a lot of folks who come in where they talk about their history, and they find like that they worked with someone and it either just wasn't a good fit, but they stayed there for a while, or it kind of devolved over time into just talking about like putting out fires for the week, or they couldn't really see progress. And I know a big part of what you're passionate about is helping people find a therapist find therapists that work for them, and to help consumers of mental health services know what quality care looks like. So can you tell us a little bit more about that side of your work and what you're doing in that space?
Yeah. So, I mean, I've been doing individual therapy for about 12 years in my private practice, and I'm just kind of reaching a point where I want to, expand my reach in terms of helping more people, getting the word out, helping consumers better understand psychotherapy. And there's also challenge. I mean, the great thing is that I think our culture has become it's less stigmatized, mental health issues. I mean, people on TikTok, a lot of consumers get their information from social media about things and sometimes it's because they can't access care, right? Because it's just like, it's too expensive. There's wait lists. So it makes sense that people are, I think that the public is hungry for how to understand these things and how to, get better. So my mission is really kind of, I want to bring, we were in school for a long time, and I feel so grateful that I had such high quality training, and I want to help consumers be thoughtful and discerning and know the information so that they can make good, educated decisions. So my platform is really meant to educate. It's meant to demystify. It's meant to also, help some people get more vetted information, as we could say, than what we sometimes get in our feeds because of just information overload. So hooking up with a therapist is another kind of question, another kind of answer, right? Like, okay, I'm ready. I want therapy. How do I find a good person? How do I find a trustworthy person? A couple tips for people, because I think a lot of people find people on certain platforms that, well, maybe what do you think is the most common one where people go to Google and they try to find someone? Do you have
Oh
a sense?
man, well I can say what the most common one is, and then the one that I like the most. So I think the most
Yeah.
common one, at least in the Chicago area where I'm based out of, far and away is Psychology Today. It's like the
Yep.
biggest repository of everybody. But my experience of it is that not that it doesn't have value because everybody's on there, but that
Yeah.
it's oftentimes hard for people to find something specific in there because there's just so much, so many people.
Yeah. Yeah. So I would really, so yes, I agree with you that that's the main place, but it's so much. And to get on there as a psychotherapist, there is some credential review. Like you have to send in, certain things, but there's not much. I mean, no one's going to vet, a therapist on there outside of making sure they do have a degree, they're licensed and so forth. But other than that, so I think that's one hard thing for consumers. So I think another way that people can find vetted, or kind of therapists that are committed to the profession, committed to ongoing learning, is through psychology or other professional organizations. So, that might be if it's more cognitive behavioral therapist, that would be like the ABC. I'm blinking on it. ABCT. Yeah, ABCT.
ABCD.
Right? Anxiety disorders, ADAA. You say what your substance use. I know what I say. Well, you're the expert there. What would be your kind of like find a provider with, SUD, expertise? What organization would you say people could go to, like their website, and be like, find a provider? And that if someone's gone on there, that they're vetted.
Mm-hmm.
They're the committed.
The funny part about that, I'm going to give a quick but multi-part answer. State to state, like every state has different addiction certification stuff. I feel like every state has their own. However, there are a couple that are useful. One is there is a board certification available in addiction psychology for psychologists. There's also an organization called NADAC, where I have a certification as a master addiction counselor, and that's a national body that does that. You can't bill under that certification, but it's kind of fragmented, but ideally you can find something in the addiction world.
So I think if a provider's they belong to a professional organization, and maybe they're on that that provider, they're getting some extra training, right? There's something there that's selling you. So the main ones because I'm more of an ACT person, I always ACBS association. And if you go to my website, psychinsideout.com, you'll see I have all the icons for different organizations that I think you could go to and say, find a provider. But so I think that's another layer that sometimes consumers don't know about. American Psychological Association. I mean, that's our main one, right? That's the national one. But there's a lot, I don't know, there's a lot of psychologists, but in the nation, but I think being board certified, like Aaron, we're kind of a little bit of a small segment actually of our, and it's but that shows this level of commitment to learning, to being overseen, to making sure that you're being, you're practicing with the latest evidence. So ABPP, those letters at the end of a psychologist's name are kind of an extra little level that people have gone to. And the other thing I would just say is there is a piece about just fit and feeling comfortable with someone. And if you're after a few sessions, just something's not feeling right, or you're not feeling optimistic about the future or what the therapy is going to provide, it's okay to turn gears and say, not for me. And therapists don't take that. I don't take that personal. I'd rather someone come to me who feels like I'm a good fit for them than have someone come and not feel that way. So it's okay to shift gears, and it's your life. You have, consumers have a voice, so they need to feel empowered to shift gears if a therapist isn't working for them.
Mm-hmm. Yeah, I think to your last point there, I think the proof in many cases is in the pudding, right? Like in terms of like if you've been working with someone for a couple months and you either don't feel comfortable or you're not seeing progress, that matters, right? And not to say you should just up and leave. You can bring it up. You can ask about different approaches, or you can go. And it's true. We therapists, we do not get our feelings hurt by and large. We understand like the fit's
I
got to
do.
be right.
I'm a sensitive therapist. So sometimes, but I tell my clients, that's on me. That's my work. That's not for you to work on. Right. So I want them to be natural. That's an exposure piece to give direct feedback, to be able to. So it's a good thing. It's a good thing for people to advocate for themselves. And if something doesn't feel like it's working, that it's okay. Just because we're in the therapist expert chair doesn't mean that I know everything about the client in front of me. So I want to really empower clients to, yeah.
Or that the fit isn't right. The metaphor I like to use is on Rotten Tomatoes. Like pick the best movie you can think of. Like it's got a 96% or 98%. There's like 1 out of 20 people in this country who doesn't like the best movie ever made. And that's just the way it goes. And
that's the way it
could be the
goes.
same
Or
way.
you're like me, and I'm like, I love that movie. It was got a 58%. I don't know why, but that was an awesome movie.
Oh man, we got a Lightyear fan here. That's right.
Oh man. Yeah. So it was, so those are the kinds of things I think when people, the other thing I would say in that early phase of working with a therapist, I think what's important, and this speaks to the kind of bridging the gap between what you're doing in therapy with progress outside in your life. I think a good therapist does a really thorough assessment at the beginning and kind of gathers a lot of information. And sometimes that is sidestepped, but and sometimes clients are like, oh, why do I have to go through all? But it's helping us as clinicians to conceptualize what could be all the things that could be going on for the person. So I think doing a really good, thorough assessment at the beginning is really important in terms of therapy. I think also having a point where you're collaborating on if this is going to be a helpful process for you, what would be different in your life? What would look different in your life? So kind of at early on, setting those goals and collaborating on those goals. And then as therapy progresses, I think the sign of a really good therapist is someone who's touching back on those goals. Where are we at? I try to give people an assessment, every few months to kind of recap, like, are we working on things? Where are we at? How are we going? Do we need to shift something? And that's really kind of helping both people because what happens is people start to like each other and they're like, oh, I like this, right? But I'm always thinking I'm still the clinician here. I want this person to grow. So we got to keep coming back to those original goals or revise them as we go along.
I love that recommendation to find someone who's data driven. I agree with you completely. The phrase that I use sometimes is that very challenging cases or constellation of symptoms aside, therapists should put themselves out of a job. Like people should be getting better to the point where they feel like they can take a break or they can taper down in sessions. And granted, again, there's some times where people really should stay in for a very long period of time, but
or they want to, and there's good evidence that it's helping them in some way, right? Like I don't want to be totally. I think there is the argument for people who really love personal growth work, and so that's okay.
and that is
to also help to get get things going, right? We need to meet the demand because there's a big demand out there.
Oh man, for sure. That's getting back now. We could spend another hour talking about mobile apps and those chatbots and everything else and about how do we meet the staggering demand. But unfortunately, we are out of time for today. So, do you have any final thoughts for us today, Jeanne? Just in terms of we talked about trauma, evidence-based work.
Follow me on LinkedIn. Follow me on Substack. Go to my website, psychinsideout.com, and I'm hoping to, really kind of help get the word out about psychotherapy, help people feel safe and comfortable, help people feel more educated as they, navigate their mental health treatment journeys. So it's just been such a pleasure to speak with you, Erin, and we'll probably have more conversations offline, right? Share some Ann Arbor VA stories, all positive.
Absolutely. All right. Well, thank you,
Okay,
Dr.
thank you
Jeanne
so
Jakob.
much,
Appreciate it.
Erin. Okay.